I'm going to discuss the topic of exogenous endophthalmitis in 2 lectures. This is the first lecture. It's a very huge topic. We need to cover all aspects of exogenous endophthalmitis. As you know, it's a very important disease. So exogenous endophthalmitis is a serious intraocular inflammatory disorder resulting from infection of the vitreous cavity. It often results in severe visual loss. Exogenous endophthalmitis occurs when the infecting organism gain entry into the eye by direct inoculation. This is different from that of endogenous endophthalmitis, such as intraocular surgery. So roughly, intraocular surgery accounts for about 7% of the cases of exogenous endophthalmitis. And as we shall discuss next week, penetrating trauma accounts for another 20 to 25% of the cases. And we have to know that these are totally different diseases. Endophthalmitis after open globe injury is totally different related regarding the microbiology, regarding treatment, and regarding the visual outcome compared to after intraocular surgery. I'm going to discuss first endophthalmitis after intravitreal injection of anti-VEGF agents. This is now the type of endophthalmitis that attracted a lot of attention, and a lot of new publications are dealing with endophthalmitis after intravitreal injection. So what I am doing today, I've summarized the current literature about this topic. Why it is important? Because nowadays, intravitreal injection is the most commonly performed ophthalmic procedure. Do you agree with this? Anyone is giving now intraocular injection. Anyone. If you look at 2 meta-analysis studies looking at the rate, the first study published in 2011 reported a rate of about 0.049%. It's low rate, but imagine a patient after injection for diabetic macular edema loses the eye because of endophthalmitis. And the second meta-analysis that was published in 2014, they estimated the rate to be about 0.056%. Again, regarding the rate, several studies demonstrated that the rate of endophthalmitis is similar among eyes receiving intravitreal injection of bevacizumab, ranibizumab, or aflibercept. So the rate was similar among these 3 drugs. Even the percentage of culture positive endophthalmitis was similar among the 3 agents. Therefore, the choice of anti-VEGF agent should be primarily based on efficacy and cost rather than concern of risk of infection. There is no difference in infection rate among the 3 drugs. Another very important point, which is using pre-filled syringes. Frequently when we give the injection, we receive from the compounding pharmacy the medication in a syringe, ready for injection. Or like for Eylea or aflibercept, we receive the bottle and we withdraw the medication in the syringe. Is that your experience also? So what is meant by pre-filled syringe? That the injections come to you in the injection room in a syringe ready for injection. So several studies showed that the use of pre-filled syringes during intravitreal injection of ranibizumab, because ranibizumab in the past more recently became available as a pre-filled syringe. So the use of intravitreal injection of pre-filled ranibizumab was associated with reduced rate of culture positive endophthalmitis, including that from the oral flora as well as improved visual acute outcomes compared to ranibizumab drawn in the clinic from the bottle. Is that clear? Because it is so that when you have a pre-filled syringe, this will reduce the manipulation to withdraw in the injection room and will reduce the infection. That's why I recently communicated with our pharmacy to provide Eylea in a pre-filled syringe. So they have to do this under in a laminar airflow under complete aseptic condition and not delete, because the two cases of endophthalmitis that I have seen them after I lay. So other studies showed that pre-filled syringes of ranibizumab decrease the rate of endophthalmitis by 40% compared to room preparation of non-pre-filled syringes and by 46% for aflipercept. Again, another study showed that sterile preloading of bevacizumab decreased the rate of endophthalmitis compared to aflipercept and ranibizumab combined, because the preparation is done in the pharmacy under complete aseptic condition. Another study showed that the rate of endophthalmitis was reduced with pre-filled syringes of bevacizumab made by a compounding pharmacy compared to bevacizumab drawn multiple times from the same vial. So the conclusion here, always use pre-filled syringes. Do you agree with this? Yeah. Okay. The second point, this is again a recent study that they compared corticosteroids versus anti-VEGF agents. And the study concluded that corticosteroid, and more specifically dexamethasone implant, or Dex, were associated with more than 3 times more endophthalmitis cases than anti-VEGF agents. So steroids, injecting steroid increased the risk of endophthalmitis 3 times. Then many studies also tried to answer this question. Do we need to give the injection in an injection room in the clinic or in the operating room? So the conclusion was that the rate of clinically suspected or culture-positive endophthalmitis following anti-VEGF injection was low, whether the procedure was performed in the office or operating room. So you can continue doing it in the office. How about microbiology, which is very important? Microbiology, I'm summarizing some recent big studies, that culture-negative cases in one study was in 50%. But in culture-positive cases, staph epi or coagulase negative eosinophil accounted for 65%. As you know, and we shall discuss this next week in the cataract endophthalmitis, coagulase negative eosinophil account for about 70% of culture positivity in patients after cataract surgery, because it is part of the bacterial flora. And it is organism of less virulence. But what is surprising here, that Streptococcus species, which is a part of the oral flora, accounted for 30.8%, very high number of the culture positive cases was due to Streptococcus species. I'm going to discuss next week that Streptococcus species cause fulminating endophthalmitis with very poor prognosis. And Streptococcus species are mainly coming from the oral flora. You have to know this so that we could talk about prophylaxis. But staph epi is coming from the ocular surface. So for prophylaxis, we have to pay attention to the ocular surface and the oral flora. So the most common organisms isolated were coagulase negative eosinophil and Streptococcus species. Coagulase negative eosinophil are coming from the ocular surface, and the Streptococcus species are coming from the oral flora. When we discuss this next week, if you look at the endophthalmitis vitrectomy study, 9% only of post-cataract surgery endophthalmitis was caused by Streptococcus species. Only 9%. But here we are dealing with 30% of a very virulent organism. That means that we have to minimize oropharyngeal droplet transmission. We should adopt no talking technique. I never talk to the patient. I never allow the patient to talk. I never talk to the nurse. So avoid talking, avoid coughing, avoid sneezing, or you might need to wear mask. Now, when a patient after intravitreal injection develop signs suggestive of endophthalmitis, it is, in many patients, it is extremely difficult to distinguish between non-infectious and infectious endophthalmitis. But if we suspect the diagnosis, we have to have a very low threshold for vitreous biopsy and injection of antibiotics. Is that clear? A low threshold to perform immersion tab and the injection of antibiotics should be maintained. Is that clear? Don't make a diagnosis of non-infectious inflammation and leave the patient. You have to go for vitreous biopsy and injection of antibiotics. How about prophylaxis of endophthalmitis after intravitreal injection of anti-VEGF agents? The most important and the only proven is to use topical bovidine iodine 5%. I personally clean the eye of the patient by myself with bovidine iodine 5% to sterilize the ocular surface. And if you are using local anesthetic as a gel, viscous gel, don't apply the anesthetic before the injection, the washing with bovidine iodine, because the viscous anesthetic will prevent contact between bovidine iodine and bacteria on the ocular surface, which, as I said, coagulates negative sulfococci. Is that clear? For those patients who have bovidine iodine allergy, you can use topical chlorhexidine. Again, as I said, physicians and patients should avoid talking, coughing, and sneezing to prevent contamination with oral flora. And oral flora means Streptococcus species, which means very aggressive inflammation, which means loss of the eye. Most of the patients who have Streptococcus endophthalmitis, their eyes were lost. A recent study published in Eye last year, they studied specifically a group of patients who were allergic to bovidine iodine. So this patient did not have wash of the conjunctival with bovidine iodine. And they found exceptionally high rate of endophthalmitis in those patients who did not have bovidine iodine. And this was a proof that bovidine iodine is very important. Now, other studies, they looked at, do we need to give pre-injection antibiotics or post-injection antibiotics? And the conclusion that pre-injection and post-injection antibiotics are not needed. There is no sufficient evidence to support routine drapping. Then, recent studies, they looked at the mask. Is it necessary to wear a mask? So the conclusion was as follows. Implementation of universal patient and physician face mask use did not significantly affect the rate of post-injection endophthalmitis compared to no talking policy. No talking policy. In fact, one paper hypothesized that if the patient wear a mask, this might increase the risk of endophthalmitis. Why? Because as the study concluded, patient face mask use may direct air and subsequently bacteria towards the treated eye, which could potentially increase the risk of post-injection. That's why nowadays, if a patient wears a mask, I remove it. Patients sometimes are surprised, but I removed it. How about the visual outcome? Of course, the visual outcome is worse for culture-positive cases. Oral flora associated endophthalmitis, which are Streptococcus and Enterococcus species, tend to have worse visual outcome compared non-oral flora, which are coagulating sulfococci. We know that coagulating sulfococci are of less virulence. And then two studies, they looked at will the patient benefit from immediate vitrectomy compared to vitreous biopsy and injection of antibiotics. And the conclusion that there was no significant difference between tab and the injection of intravitreal antibiotics and the Barza and vitrectomy. So perhaps when you see the patient in the emergency room, immediately go for biopsy, inject antibiotics. If the patient needs vitrectomy later on to to clear the media, yes, you can do it. But as an emergency situation, you don't need vitrectomy, and that's what, this is our policy. The cases that I have encountered with post-injection endophthalmitis, I only gave intravitreal antibiotics. Another type of endophthalmitis that I personally faced 2 patients, and that's why we changed our technique in the clinic, is endophthalmitis following suture removal. Who of you know about this type of endophthalmitis after suture removal? And who of you saw a patient with endophthalmitis after removing corneal suture? You never saw it? You never heard about it? I personally saw some cases, and based on this, we wrote a memo to all our colleagues what should to do before they remove the suture. So this is acute and fulminant type of endophthalmitis, very aggressive. Streptococcus pneumonia is the most isolated organism and with poor visual outcome. So we told all our colleagues, before you remove the suture, you have to clean the eye with 5% povidone iodine. Before and after the procedure, you use sterile instruments, and one paper suggested that to reduce the risk, you can cut the suture in one of the external corners of the loop to prevent access of the exposed part of the suture to the inside of the eye, to avoid rotating the exposed part inside the eye. Now we'll move to post-cataract extraction endophthalmitis. We have 2 main types of post-cataract endophthalmitis. The acute type, which develop within few days, and the chronic type that can develop 1 month or more after cataract surgery. This is, so the acute post-cataract endophthalmitis occurs shortly after surgery, most present within 1 or 2 weeks of surgery, often within few days. How about the incidence? We know that cataract surgery is the most frequently performed intraocular surgery. Therefore, 90% of post-operative endophthalmitis occurs following this procedure. The rate of the endophthalmitis after cataract surgery in the 1990s was only 0.087%, but increased 4 times after 2000, after year 2000. It increased to 0.265. Why? It's increased because of the start of using what's called sutureless clear corneal incision. The surgeons were interested in doing sutureless clear corneal incision, and it has been shown that these incisions are not stable, and this increases the risk of endophthalmitis. Therefore, we advise all our colleagues nowadays to put 1 suture. Do they do this now?
Yes.
Huh?
Yes. Most are suture.
Most, they leave it open. But this increases the risk of endophthalmitis.
Also suture removal increases.
Huh?
Again, suture.
No, if you do it with the conditions that I just discussed, there is no risk. Okay. So the studies showed 3 to 4 times increased risk of endophthalmitis in clear corneal incisions compared to scleral tunnel incisions. Again, another study showed that the rate of endophthalmitis at 1 year were 0.13% after cataract extraction alone. But if the cataract surgery is complicated with opening the capsule and vitrectomy, this increases the risk of endophthalmitis to 0.58%. If you do vitrectomy to manage the complication, this will increase the risk about 4 times. So that means that perhaps this patient will need special prophylactic precautions. And the risk is exceptionally high after secondary, nobody knows why, after secondary intraocular lens implantation. So if you have complicated cataract surgery, if you have secondary intraocular lens implantation, the risk is exceptionally high. So these are also more studies that showed that clear corneal incision increase the risk. Also, this study shows that if you use silicone intraocular lens optic material, increase the risk compared to acrylic lens material. I don't know why silicone intraocular lens optic material increase the risk of endophthalmitis. And as I said, presence of a surgical complication increase the risk by 5 times. So these are also other articles that showed that clear corneal incision increase the risk. So many studies confirmed that clear corneal incision, which is left without sutures, increase the risk. And also, these studies showed that communication between the anterior segment and the vitreous due to capsular tear or significant xenolysis without vitreous loss can increase the risk of endophthalmitis. Old age can increase the risk of endophthalmitis. Now, how about microbiology of post-cataract endophthalmitis? The majority of bacteria causing post-cataract endophthalmitis is coming from the lid margin and conjunctiva. And these are mostly coagulase negative fullcocci. In the endophthalmitis vitrectomy study, using genetic analysis, showed that about 70% of the coagulase negative staphylococci isolated from the eyes with endophthalmitis are the same as bacteria colonizing lid margin conjunctiva, which means that the main source is coming from the patient's flora, which means that we have to pay a lot of attention to make sure that the patient, that we clean the ocular surface. In the endophthalmitis vitrectomy study, the endophthalmitis cases were culture positive in about 70%. The majority were gram-positive isolates, 95%, and about 6% were gram-negative bacteria. So the majority, gram-positive isolates. Among the gram-positive cases, coagulase negative staphylococci accounted for 70%. And this is good news for post-cataract endophthalmitis. The majority of the cases are caused by less virulent bacteria. Staphylococcus, about 10%, and I told you, Streptococcus species, 9% only. But in the post-injection endophthalmitis, 30%. And also, the risk of Streptococcus infection after open globe injury is even more. And that's why in many patients with after post-injection endophthalmitis, the prognosis is bad because 30% of the isolates were Streptococcus species. So if you are faced with a case, we clinically can suspect the diagnosis because the patient has pain, has reduced vision on examination, hypopion, fibrinous reaction. If you have access to the fundus, retinal vasculitis is a common feature. The endophthalmitis vitrectomy study showed that blurred vision was diagnosed in 94% of the cases, red eye 82%, but pain in 74%, swollen lid in 34%. This is an example of a case of post-cataract endophthalmitis. The cultures. We should do culture, we should get a sample, and we'll do culture to identify the organism. From where to get the culture? Vitreous or aqueous? Which one you would prefer? Of course, vitreous. In the most of the patients, the vitreous biopsy is the one that will show bacteria. In most of the cases, the aqueous will be negative. So we should get a vitreous biopsy. We can do vitreous aspiration by inserting a needle behind the at 3 millimeter behind the limbus and aspirating some vitreous. And many people, they prefer to use a vitrectomy instrument to avoid traction on the vitreous. If you are going to do Barzo-Plana vitrectomy, so we always do 2 techniques. We get, at the start of the procedure, we get a concentrated sample in the syringe before we open the infusion line. And we send the cassette at the end of at the conclusion of the surgery that contain all the fluids that came from the eye to the microbiology lab, where they can centrifuge it and culture the concentrated pellet, or they can run the material through a filter and then cut it in small pieces and culture it. Some study, an old study, shows that culturing the cassette, the vitrectomy cassette, improve the possibility of culturing the organism. We have to do gram stain for fungi. The culture should be aerobic, anaerobic, fungal, and we do antibiotic sensitivity. Anaerobic cultures, this is important when we talk about propionibacterium, acne, endophthalmitis, should be kept for at least 14 days. Nowadays, with the ability of molecular biology, like PCR, it increases sensitivity of culturing the organism. Again, whole genome sequencing was found also to be useful for endophthalmitis identification of the organism, and also even metagenomic next generation sequencing was found to be useful. Treatment. Patient need intravitreal injection of antibiotics, and the best combinations that will combine both gram-positive, gram-negative, vancomycin 1 milligram in 0.1 ml plus ceftazidime 2.25 milligram 0.1 ml. Many years ago, we were using to cover gram-negative isolates aminoglycosides, amikase and gentamicin, but we stopped this because of toxicity to the retina by amikacin and gentamicin. There was some interest in injecting corticosteroids like dexamethasone in addition to antibiotics, 400 microgram 0.1 ml. I never did this because I saw that perhaps topical steroids might be enough. And then I'm giving you a summary of two meta-analyses that discussed the adjunctive steroid therapy versus antibiotics alone for acute endophthalmitis after intraocular surgery. So the first study that was published in 2018 concluded that intravitreal dexamethasone without preservatives as an adjunct to intravitreal antibiotic alone does not improve visual acuity in patients treated for suspected bacterial endophthalmitis after cataract surgery. So we don't need to give dexamethasone. The second study concluded that current evidence on the effectiveness of adjunctive steroid therapy versus antibiotics alone in the management of acute endophthalmitis after intraocular surgery is inadequate. So we can conclude from here the most important is intravitreal vanco and ceftazidime. Barzilplanar vitrectomy, there was a lot of debate when should we do barzilplanar vitrectomy for therapeutic reasons in patients with post-cataract endophthalmitis. Before the availability of the data that came from this study, big study, I had this impression that if a patient comes with dense vitreous involvement, no red reflex, this is so that means that the eye is full of pus. This is an indication to do early vitrectomy. So the study demonstrated that vitrectomy is useful if the visual acuity at presentation was only light perception. Vitrectomy was useful. But if the vision was hand motion or better, there was no difference in the outcome. So conclusion here is that if the vision is only light perception, you have to do early vitrectomy. If the vision hand motion or better, you can go for vitreous tab and injection of antibiotics. This is the typical example of a patient that I'll go for vitrectomy. No reflex. The vitreous is full of pus. This is before and this after vitrectomy. Now, in diabetic patients, the situation is different. If the patient is diabetic, the study showed that if a patient is diabetic, even if the vision is hand motion or better, it's better to go for vitrectomy. As you know, diabetics are immunocompromised. So it's very important to know if the patient is diabetic or not. If the patient is diabetic and patient is hand motion, even if it is hand motion or better to go for vitrectomy. How about systemic antibiotics? That was also looked at. The study concluded that the most important antibiotics will be intravitreal. Systemic antibiotics did not help. So you don't need to give systemic. However, the combination that was selected by the study was very funny. They combined amikacin and ceftazidime. Amikacin will cover which bacteria? And ceftazidime? And the most of the bacteria isolated are positive. That was, if you go back to the literature, you will see that this combination received a lot of discussion and a lot of objections. So, but based on this combination, which is not a correct combination, using two antibiotics that both of them are effective for gram-negative isolates, not gram-positive, this combination, the use of systemic antibiotics did not help. That's what I wrote here. Intravenous antibiotics used in the endophthalmitis vitrectomy study were not optimal choices. So what are the risk factors for poor visual outcome? The same study looked at factors predicting poor outcome after treatment. If the initial visual acuity is poor, only light perception. So it has been shown that the initial vision is the most important predictor for the visual outcome. The most important predictor. If the patient is presenting with poor vision, only light perception, this is the most important predictor for poor outcome. Older age, history of diabetes, corneal infiltrate or ring ulcer. It is a sign of an aggressive organism. I have seen this in few patients. If a patient has no presentation, they have a ring ulcer or corneal infiltrate, this is a sign of aggressive organism. Abnormal intraocular pressure, either low or high. A small pupil size after maximal dilation. I'm still talking about risk factors for poor visual outcome. Afferent pupillary defect, rubiosis iridis, open posterior capsule, absent red reflex, inability to see any retinal vessels by indirect ophthalmoscopy. This is obvious. These are criteria of very aggressive inflammation, most likely due to aggressive organism. And what were the microbiologic factors for and related to visual outcome? So the best outcome was reported in patients with gram-positive coagulase negative staphylococci. This is understood because this is bacteria, as I said, it is virulent. Followed by Staph aureus. Streptococcus, only 30% achieved good outcome. How about prevention? Now we knew about the microbiology, we knew about risk factors. So to prevent post-cataract endophthalmitis, you need to do the following. Any pre-existing conditions such as conjunctivitis, blepharitis, dacryocystitis should be treated. That's why, in my experience, I never operate a patient unless I saw the patient in the pre-op round 1 or 2 days before surgery. So bringing a patient, booking a patient to have cataract surgery after 3 weeks, 1 month, and then bringing the patient direct to the theater, I don't think it's a good idea. You have to examine the patient carefully immediately before surgery to rule out conjunctivitis, blepharitis, or dacryocystitis. Because the most common bacteria causing post-operative endophthalmitis are expected to come from the patient's conjunctiva or eyelids. This is the most common source of bacteria. You have to make sure that the patient has no blepharitis. There's no conjunctivitis. Then the question is, do we need to give pre-operative, post-operative topical antibiotics? There is no proof that this will help. Even subconjunctival antibiotics, there is no data to support this. But the most important prophylactic measure, again, is topical 5% povidone iodine in the conjunctiva before surgery, and this is the one that had proven efficacy. So I'm emphasizing here for post-suture removal endophthalmitis, to prevent endophthalmitis after intravitreal injection of anti-VEGF agents, and to prevent endophthalmitis after cataract surgery, meticulous wash of the conjunctival sac with povidone iodine. Again, the incidence could be reduced by suturing corneal incisions, putting a drop of povidone iodine drops after closure. These are other preventive measures. But nowadays, for some years ago, there was a heavy discussion about intracameral injection of antibiotics at the conclusion of the surgery. So the European Society of Cataract and Refractive Surgery, they wrote the first report that the use of intracameral cefuroxime, 1 milligram and 0.1 ml, this reduced the risk of endophthalmitis. I know that some colleagues currently, they use routinely intracameral cefuroxime after cataract surgery. And the absence, if you don't, in their study, the absence of intracameral cefuroxime prophylactic regime was associated with about 5-time increase in the risk of postoperative endophthalmitis. Again, another antibiotic that was tested is intracameral moxifloxacin. Again, intracameral moxifloxacin was found to be effective. The conclusion is that intracameral antibiotics are more effective than topical antibiotics alone. Again, many studies show that intracameral antibiotic therapy is the best choice for preventing endophthalmitis after cataract surgery. Would you go for intracameral antibiotics in all patients? I had an opinion that we knew now what are the risk factors for endophthalmitis. For example, if you have complicated cataract surgery, a patient who is diabetic, secondary intraocular lens implantation, then perhaps we can reserve intracameral antibiotics for those high-risk cases. This is my personal opinion. Now, you have to be very cautious because it has been reported that people were using also vancomycin intracameral. And as a complication of intracameral vancomycin, some of the patients developed post-operative hemorrhagic occlusive retinal vasculitis. Therefore, we should not use vancomycin. In fact, I'm surprised because we are using very frequently intravitreal vancomycin for endophthalmitis. But this has been reported after intracameral vancomycin. Then two big studies published 2018-2020, they did comparative analysis of the safety and the efficacy of intracameral cefuroxime, moxifloxacin, and vancomycin at the end of cataract surgery, a meta-analysis. Conclusions. Intracameral antibiotics decreases the incidence of postoperative endophthalmitis. This is well established. Intracameral antibiotics alone may be as effective as intracameral plus postoperative topical antibiotics. So if you give intracameral, you don't need to give postoperative topical. Intracameral cefuroxime had minimal toxicity events at standard doses. Intracameral moxifloxacin was the most studied antibiotic for safety and found to have low toxicity profile at all studied concentration. So this has a broad range of safety, moxifloxacin. Intracameral vancomycin has been associated with hemorrhagic occlusive retinal vasculitis, resulting in visual acuity worse than 20/200. So this is all what I wanted to tell you about post-cataract, acute post-cataract endophthalmitis. Do you have any questions for this part of the lecture? Now we'll move to another type of post-cataract endophthalmitis that unfortunately is not recognized by many colleagues and frequently missed, which is the chronic microbial pseudophakic endophthalmitis. So what is peculiar about this type of endophthalmitis? That it can present 1 month or more after cataract surgery and may persist for several months thereafter. So this is a typical feature for this. Every one of us should have this in the back of his mind, so that in order not to miss a case. The patient can come with uveitis 1 month or more after cataract surgery. It follows cataract extraction and posterior chamber intraocular lens implantation. It is associated with persistent low-grade inflammation, which can masquerade as granulomatous uveitis. Patient can have bottom fat KPs. And most of these patients are treated as uveitis without thinking that this is a chronic endophthalmitis. And what is even more confusing, that this patient, they show transient response to topical corticosteroids. You give the patient topical corticosteroids, they respond. When you taper it, inflammation recurs. Many cases are misdiagnosed as sterile postoperative inflammation, can develop or worsen following neodymium YAG laser posterior capsulotomy. And this is hypothesized to be due to lyopressin, release of previously loculated organisms. So the organism typically is a low virulent organism that need to be sequestered between the intraocular lens and the capsular bag. And when you do the YAG capsulotomy, the organism is released and causing the inflammation. When this disease was first described in the literature, it was associated with Propionibacterium acne and organisms of low virulence. So clinically, this is an indolent, gradually progressive, low-grade granulomatous uveitis weeks to months after cataract surgery. It responds to corticosteroid therapy, at least initially. One of the typical clinical features of the disease is the presence of white plaques between the intraocular lens and the capsule. So white plaques within the peripheral capsular bag or between the intraocular lens and posterior capsule. And this white plaques represent colonies of organisms, sometimes mixed with residual lens material. And this is an important sign because it can be present in 40% to 100%. This is an example. This is one of the first cases that at the time when I saw this patient, nobody knew. Many years ago, I presented this case in the grand round, and at that time, most of the audience did not know about chronic endophthalmitis after cataract surgery. So you can see that this patient, and the quality is not very good, but you can see the white plaques between the intraocular lens and the capsule, and this represents colonies of the organism. And this is another example. Another example. So granulomatous KPs can be seen in up to 80%, bottom fat KPs. Hypopion, up to 63% of the cases. This is an example of a case with bottom fat KPs. Hypopion. And that was a patient that I managed recently. Look at the patient. The patient had uncomplicated cataract surgery done in another institute. And what are these on the cornea? Bottom fat KPs. And what are these? Whitish plaques. So we made the diagnosis, immediate diagnosis, that this patient had chronic endophthalmitis. And he was, as far as I remember, he had the cataract surgery done 3 months before he presented to us. These patients also, because of the chronic inflammation, they can have granulomatous deposits on the surface of the oil. You see the intraocular lens full of deposits, vitritis in most cases. So this is an example of a patient. You can see this granulomatous deposits on the intraocular lens. There's a big list of organisms that can cause chronic endophthalmitis after cataract surgery. So I said the common feature about all these organisms is that they are of low virulent. The most common bacteria is Propionibacterium acne. This is anaerobic gram-positive polymorphic bacillus. that demonstrates extremely slow growth characteristic on culture media. That's why if you suspect it, you have to instruct your microbiology lab to keep the culture for 2 weeks. Otherwise, it will come negative. It is very difficult to culture. The organism sequester between the intraocular lens and posterior capsule, and this encapsulated state protects the organism from antimicrobial agents. This type of endophthalmitis will never respond to intravitreal antibiotics alone, and I'll show you later. So the encapsulated state protects the organism from antimicrobial agents and normal host defense mechanisms, leading to recurrence after standard endophthalmitis treatment. We have to culture the aqueous and vitreous. The specimen as should be, we should use aerobic and anaerobic culture. The culture should be maintained for 2 weeks. And at the time of vitrectomy, I shall discuss with you this later, if you excise the capsule, you have to culture this excised piece of capsule because this will increase the yield of the organism. We always do also, if we excise the capsule, we do histopathology of the excised capsule. It has been shown that PCR is a useful adjunct to conventional culture. This is a patient that I treated years ago, and this is the excised capsule. We did staining for the capsule, and that will show gram-positive bacilli. Now, what are the treatment options? You can use intravitreal antibiotics alone, or vitrectomy plus intravitreal antibiotics, or vitrectomy, partial capsulectomy. You excise the posterior capsule and you inject intravitreal antibiotics and you leave the intraocular lens. Or you can do vitrectomy, total capsulectomy, intravitreal antibiotics, and you remove the intraocular lens. There is grading of your choices. But I'm going to show you what is the outcome. These are the 2 largest studies. I combined them together that looked at this issue. If you use only intravitreal antibiotics, 93% of the cases will not respond. So the choice of only intravitreal antibiotics is not a good choice. You agree? Right. If you use vitrectomy and you retain the capsule, so if you use vitrectomy, intravitreal antibiotics, and you retain the capsule, 50% will recur. So this is not a very good choice. If you use vitrectomy plus excision of the posterior capsule, the center, at least the central part, and what I usually do, at the time of vitrectomy, I excise the posterior capsule with the vitreous scatter and inject the antibiotics in the capsular bag, then only 26% will recur. Then, if there is no response, you do vitrectomy, you do complete excision of the capsule, you inject the intravitreal antibiotics, you remove the intraocular lens, then 100% success. So before I do this, I do vitrectomy, I excise the posterior lens capsule, and we had success in most of the patients with this technique. So we keep the intraocular lens, but we have to excise the posterior lens capsule. We inject antibiotics also in the capsular bag, and most of the patients will respond. So conclusion, Propionibacterium acne endophthalmitis after cataract extraction presents many diagnostic and therapeutic challenges, but if we suspect it, if we look for it, we'll not miss it. Propionibacterium acne endophthalmitis should be considered in all pseudophakic patients with chronic intraocular inflammation. Don't manage the patient as a case of strial inflammation or uveitis if the patient had cataract surgery. White intracapsular plaque, cratic precipitates hypopyon, vitritis may be present. Temporary response to corticosteroid therapy. Laboratory should hold the culture for at least 2 weeks. Reasonable treatment choice include vitrectomy and intravitreal antibiotics with either partial capsulectomy or total capsulectomy and IOL removal. In patients with recurrent inflammation, partial vitrectomy, total capsular bag removal, intravitreal antibiotics, and IOL removal is successful in most of the patients. Visual outcome, if you compare it with acute endophthalmitis, is much better. And this has been shown in this publication, that they compared the outcome and the clinical presentation in acute endophthalmitis versus delayed onset endophthalmitis. So they defined acute endophthalmitis if the inflammation starts 6 weeks or less after surgery, and the chronic endophthalmitis if the inflammation starts more than 6 weeks after surgery. So they had 118 patients in this study. 26 were delayed onset or chronic, and 92 were acute onset. So what were the differences? The presenting visual acuity was significantly better in eyes with chronic endophthalmitis. This is understood. Hypopyon was more in eyes with acute endophthalmitis. The most frequent isolates in chronic endophthalmitis were Propionibacterium acne, and in acute endophthalmitis, coagulase negative staphylococci. The visual outcome was significantly better in chronic endophthalmitis. In the late onset cases, the intraocular lens was removed or exchanged in 73% of the patient because he did not respond, so we had to remove the intraocular lens. Of these 19 cases in which you had to remove the intraocular lens, 13 achieved visual outcome of 20/100 or better. Thank you very much for your attention.